Billroth surgery is a partial resection of the stomach with anastomosis to the duodenum. Billroth 1 or to the duodenum. Billroth 2 is a standard treatment for ulcer disease, stomach cancer, injury, or other diseases of the stomach. These were first described by Theodore Billroth, the pioneer in modern anterior surgery. So Billroth 1 and Billroth 2. Billroth 1 is also called gastroduodenostomy. It involves the partial gastrectomy or removal of the antrum or and pylorus of the stomach with anastomosis of the gastric stump to the duodenum. Billroth 2 is also called gastroduodenostomy. It involves the partial gastrectomy or removal of the antrum and pylorus of stomach with anastomosis of the gastric stump to the duodenum. Procedure: after removing a piece of the stomach, the surgeon reattaches the remainder to the rest of the body. Billroth 1 gastroduodenostomy specifically joins the upper stomach back to the duodenum, while Billroth 2 joins it to the jejunum. So, what is the procedure? After removing a piece of stomach, the surgeon reattaches the remainder to the rest of the bowel. Billroth 1 is gastroduodestomy specifically joins the upper stomach back to the duodenum, while Billroth 2 joins it to the jejunum. First, they remove the piece of the stomach, and the surgeon reattaches the remainder to the rest of the bowel. So they remove the portion of the stomach. You can observe that this portion of the stomach is dissected, and the duodenum or the stomach is joined to the duodenum. This is first one. What they prepare? They prepare medical assessment, intravenous or muscular administration antibiotic insertion, internal line for alternative supply of compactable blood. So they are supplying nutrition blood, dressing and installation, post-operative monitor vitals, operation site, assess for site of infection, pain medication as ordered, side effects, duodenal gastric reflux, persistent vomiting, dumping syndrome, often after a meal characterized sweating, abdominal pain, vomiting, lightheadedness, diarrhea, low blood sugar levels, hypoglycemia after a meal, absorption of necessary nutrients, especially iron, in patients who had all of the part of the stomach removed. These are the side effects of Billroth surgery next is bladder cancer. So what is bladder cancer? Bladder cancer is a papillomatous growth in the bladder urothelium that undergo malignant changes and that may infiltrate the bladder wall. So it's a papillomatous growth in the bladder. So papilloma is forming in the bladder urothelium that undergo malignant change and that may infiltrate. Urothelium means outside the bladder wall. So this is due to cigarette smoking, exposure to chemicals, radiation. Common sign of metastasis include the liver, bones, and lungs. So signs of metastasis include the liver, bones, and lungs. As tumor progress can extend to the rectum, vagina, and retroperitoneal structures. So the tumor can be progressed. The papilloma fat or the papilloma growth can be into the full of the wall, and after that into the rectum and vagina and retroperitoneal structures. Next is what are the assessment? Painless hematuria, dysuria, gross hematuria, obstruction of urine flow, development of fistula, urine from vagina, fecal material in the urine. So there may be pain in the urination. There will be dysuria, gross hematuria with blood. So there will be blood, because there will be peritoneal fat will be destructed. Development of fistula. But diagnosis what we do? So biopsy of that place, we can take biopsy because are definite. Cytoscopy, biopsy of tumor, adjacent mucosa. Excretory urography, computed CT scan, ultrasonography, bimanual examination by anesthesia, cytological evaluation of fresh urine and saline bladder washing. So what are the diagnostic evaluations? Cytoscopy, biopsy, excretory urography, computed CT scan, ultrasonography, bimanual examination by anesthesia, cytological evaluation of fresh urine and saline bladder washing, molecular assay, bladder tumor, antigen adhesion molecules and other are being studied. Primary nursing diagnosis, risk for altered urinary elimination related to the obstruction of urinary flow. Medical management, radiation. Most bladder cancer are poorly radiosensitive and require high doses of radiation. Radiation therapy is more acceptable for advanced disease that cannot be eradicated by surgery. So what are the medical management? Radiation. Most bladder cancer are poorly radiosensitive. So the bladder cancer will be radiosensitive and require high doses of radiation. Radiation therapy is more acceptable for advanced disease that cannot be eradicated by surgery. So therapy is more advanced acceptable for advanced disease. Palliative radiation may be used to relieve pain and bowel obstruction and control potential hemorrhage and leg edema caused by venous or lymphatic obstruction. So bladder cancer are poorly radiosensitive and require high doses of radiation. Radiation therapy is more acceptable for advanced disease that cannot be eradicated by surgery. Palliative radiation may be used to relieve pain and bowel obstruction and control potential hemorrhage and leg edema caused by venous and lymphatic obstruction. So what happens is medical management, they are radiosensitive. The poorly radiosensitive is the high dose of radiation. So there will be radiosensitive. Radiation therapy is more acceptable for advanced disease that cannot be eradicated. So if there is no surgery, we can use radiation therapy. Palliative radiation may be used to relieve pain and bowel obstruction and control potential hemorrhage, leg edema, caused by venous and lymphatic. So palliative radiation can be used, radiation therapy can be used, there is no surgery, and high dose radiation will be needed because there is less more sensitive, very sensitive. Intracavical radiation may be prescribed when which protect adjacent tissues. External chemotherapy or surgery may be prescribed because the external radiation alone may be ineffective. So intracavitary radiation may be prescribed, which protect adjacent tissues. External radiation combined with chemotherapy. Extracavitary radiation may be prescribed, which protect adjacent tissues. External radiation combined with chemotherapy or surgery may be prescribed because the external radiation alone may be ineffective. Complication of radiations: a bacterial cystitis, proctitis, fistula formation, initis or colitis, bladder ulceration and hemorrhage. So bacterial may be there, proctitis will be there, fistula may be found in there, colitis may be there, ulceration will be there, hemorrhage will be there. So fourth one, intracavitary radiation is which is compact. This can protect their adjacent tissue with no damage. Radiation the adjacent tissue also down. External radiation combined with chemotherapy surgery is prescribed. External radiation may allow be ineffective. So with chemotherapy also you can give complication of radiations, bacterial cystitis. Next is chemotherapy, intravesical instillation. An alkaline chemotherapy is instilled into the bladder. This method provides an concentrated topical treatment with little systemic absorption. So there will be a treatment topically. The whole the system is not absorbing, only in the area is absorbing. Chemotherapeutic agent may usually include Thiotepa is chemotherapy drugs. Thiotepa is a chemotherapy drug. Mitomycin is a antibiotic plus glutamycin, doxorubicin, adrimycin, cytoxan, cyclophosphamide, and bacillate calamate glurine. Bacillate calamate glurine, Thiotepa, mitomycin, doxorubicin. These are the chemotherapeutic agents used in bladder therapy. Mitomycin, doxorubicin, cyclophosphamide. What are the Thiotepa, mitomycin, glutamycin, doxorubicin, cyclophosphamide, bacillate calamate glurine, cyclophosphamide. Don't stand. So these medication are injected into the medication is injected into the urethral catheter and retained for 2 hours. It is injected into the urethral catheter and retained for 2 hours. Following installation, the client position is rotated every 15 to standing supine to avoid lying on full bladder. So we have to avoid lying on full bladder, and installation only within 2 hours. After 2 hours, the client work in sitting position instructed to increase fluid to flash the bladder. Sitting position. Treat the urine as biohazard, sent to radioisotope laboratory for monitoring. 6 hours after intravesical therapy, disinfect the toilet with household bleach after the client has voided. Systemic chemotherapy. Systemic is to treat inoperable or late tumors. Agent will use platinum. So systemic chemotherapy is the second one. First is just a normal chemotherapy in intravesically. This is systemic. In systemic chemotherapy, this type of drugs are used only late tumors or inoperable tumors are used. So like that, we will use cisplatin, platinol, doxorubicin, adrimycin, cyclophosphamide, sulfonamide, methotrexate, Forex, pyridoxine. Complication: bladder irrigation, hemorrhagic cystitis, Surgical intervention, transurethral dissection of the bladder. So what we do surgically? Local resection and fulguration, destruction of tissue by electrical current through electrodes placed in direct contact. So they are destructing the tissue. Transurethral dissection. After that, perform for early tumor for cure or inoperable tumor for palliation. Partial cytectomy. Partial site is removal of up to the half of the bladder. The procedure is done for early tumors and for clients who cannot tolerate radical cystectomy during the initial. So partial cystectomy is half of the bladder. Half of the bladder is removed. The procedure is done for early tumors and for clients who cannot tolerate radical cystectomy. So it is done for radical. During the initial postoperative period, bladder's capacity is reduced greatly to about 60 ml. As the bladder tissue expands, the capacity increases to 200 to 500 ml. So postoperatively, the period capacity is reduced greatly to 60 ml. However, the blood tissue expands, the capacity is 200 to 400 ml. So in postoperatively 60, after the version 200 to 400 ml can be possible. Veins and continuous output of vein following surgery is critical to prevent bladder dissection and stress on the structure. So, Maintenance of a continuous output of urine following surgery is critical to prevent bladder dissection and stress on the structure line. Continuous output of urine after the surgery is critical to prevent bladder dissection or stress. Urethral catheter or suprapubic catheter may be placed in the suprapubic catheter may be left in 2 weeks until suprapubic catheter can be placed until 2 weeks. Next is cystectomy and urinary diversion. So first one is chemotherapy, then radiation, then systemic chemotherapy, then cystectomy, half of the bladder removal, partial cystectomy, systemic and urinary diversion. Procedure to remove the bladder, urethra and lumen and bladder, usually the prostate and urine residue. When the bladder removed, urinary diversion is required. The surgery may perform in these stages if the tumor is expensive. The creation of the urinary diversion first and cystectomy several weeks later. If radial system looking low, exudating lymphedema may occur as a lymph node dissection and both ends may occur in the blood. Some simple lymph node dissection. The lymph node in the ground. Manual conduit is also called urethro and or breakfast procedure. Urethras are implanted into a segment of the ileum with the formation of an abdominal stomach. So ileal conduit is also called ureterostomy or breakfast procedure. Ureters are implanted in the segment of the ileum with the formation of abdominal stomach. So in this one there is a ureterostomy or breakfast procedure. Ureters are implanted in the segment of the ileum with the formation of an abdominal stomach. The unit hole will conduit and propel continually out to the stomach of peristalsis. So the client is required to wear appliance on stomach to collect the urine. So the client is doing breakfast procedure. The client is used to cleanse for the stomach. So the urine is poured into the conduit and propelled continually out to the stomach of peristalsis. Complication include obstruction, pneumonitis, leakage at anastomosis site, stenosis, hydronephrosis, calculosis, skin irritation and ulceration and stomach defect, or pouch. Isam containment, internal ileal reservoir taken from a segment of the ileum and assembly column. The ureter may be implanted in the side of the reservoir and special little valve is constructed to attach the reservoir to the skin. Post-operatively, the client will have 24 to 26 folio catheter in place to drain urine continuously until the pouch has filled. The catheter is irrigated gently with endless to prevent obstruction from mucus or clots. Following removal of the catheter, the client is instructed on how to self-catheterize and to drain the reservoir at 4 to 6 hour intervals.